My name is Kasia, and I am here to introduce the first session of this symposium, titled The Importance of Antimicrobial Stewardship. To kick off this session, we are joined by two incredible guests, who I have the privilege of introducing. Let's welcome Huda Razzak and Rob Purdie to the stage. I will provide their backgrounds together because they will be presenting together. So I will begin. Huda Razzak is a registered dietitian and a graduate from McGill University and a member of the Order of Dietitians and Nutritionists of Quebec. She currently works at Action Sport Physio. At McGill and other forums like this one, Ms. Razzak engages as a guest speaker. When she speaks, she highlights the critical role of nutrition in respiratory health through a unique and personal lens. Living with cystic fibrosis, she experiences the long-term effects of antibiotic use and the reality of antimicrobial resistance firsthand. Her dual perspective, as both a patient and a healthcare professional, drives her advocacy for increased investment in research. Passionate about sharing her journey, she uses her voice to raise awareness, educate, and inspire meaningful change in healthcare. Rob Purdie is a nationally recognized patient advocate and managing director of the MyCare Foundation, the first patient-led pan-fungal nonprofit in the United States. Diagnosed with coccidioidal meningitis in 2012, he has dedicated his career to advancing research, education, and policy for fungal diseases. Rob contributed to developing the first patient-reported outcome tool for disseminated coccidioidomycosis and has co-authored publications in Clinical Infectious Diseases, The Lancet, and Mycopathologia. He serves on the World Health Organization Task Force for AMR survivors and continues to amplify patient voices in global health and antimicrobial resistance policy. With that, I hand it over to Rob and Huda. Thank you.
Thank you. So I'd like to extend a thank you for hosting me, as well as Huda, this morning. And we thought it would be really great to start off an AMR conference with a very, very central topic to AMR, which is fungal diseases from the U.S. perspective, right? Nothing's more central to this topic than that. So I'm not going to spend a lot of time introducing myself. I'm going to talk a little bit about, I'm going to frame my story a little bit and then talk a little bit about what it was like to be diagnosed with a fungal infection. So I've been living with disseminated coccidioidomycosis since 2012. It's the only time I'm going to say the word. Not disseminated, I can say that all day long. It's the other word, which is why nobody says that. They call it cocci or valley fever. And why is that important? This is a disease that's generally associated with the southwestern United States. But why does that matter in Canada, and why do fungal diseases matter in Canada? Well, for starters, there has been some climate modeling that puts the distribution of cocci into south central Canada by the end of the century. And if you think that's a bridge too far from Arizona and California, keep in mind that southeastern Washington has been established as endemic for this organism. So it is closer than you think. And then I personally know patients, Canadian patients with my disease, because we live in a global community. And my story is not just about valley fever, it's about AMR. It's about what happens when diagnostics and the system built to treat infectious diseases and fungal diseases fails, and why. So my initial symptoms started on New Year's Day 2012. So I'm very lucky because my memory is shot that I have some very good benchmarks for timing. So for example, New Year's Day, very easy to remember. New Year's Eve, I was starting to feel flu-like illness coming on, was probably in bed by 8 o'clock, maybe it was 9 o'clock. Did not ring in the new year, woke up New Year's Day with the worst migraine I've ever experienced. I just stayed in bed on and off for the better part of a week, doing as little work as I could. Didn't get better, so I did what most Americans do and what most people do when they have an illness. I went to my first line source of health care, which in the United States is an urgent care, where I had a lovely 30-second conversation with a doctor, at which time he said, well, it's a sinus infection, prescribed antibiotics. Completed that 10-day course of antibiotics, and I'm happy to say at the end of that 10-day course of antibiotics, I felt much worse. So I determined that that physician was an idiot, sorry, and did what anybody else would do, and I went to an entirely different urgent care, an entirely different physician who, after another 30 seconds, diagnosed me with the exact same thing and prescribed a different antibiotic. And lucky for me that after I started taking the antibiotics and continued to feel worse, I went to an ENT specialist, and he was able to tell me through some imaging that I, in fact, did not have a sinus infection. My next diagnosis was cluster headaches. And it wasn't until early February, keep in mind, we're now 5 weeks in, that that my symptoms deteriorated further. I was actually giving a specific talk with a PowerPoint, and because I wasn't feeling well, my wife was with me, she drove me, and she'd heard me talk before. So at the end of the talk, I went up to her and I said, well, how did I do? She's all, I could tell you were sick, but I think you did okay. Nobody else could tell. I'm like, well, about halfway through the PowerPoint, I started to see 2 of everything. Then went to a local community hospital in my hometown in Central California. And believe it or not, there's a lot of, we can draw a lot of similarities between aspects of the rural Canadian healthcare experience and Central California, which is a very rural agronomic community, or group of communities. But was brought into the emergency room, was actually given a differential diagnosis by a resident, and had my first lumbar puncture in an emergency room in a community hospital in Central California. Was admitted to the hospital, and for Valentine's Day 2012, I was diagnosed with a fungal meningitis called coccidioidomycosis. And only when it comes to fungal infections do I think that it is acceptable that I had meningitis for 6 weeks prior to diagnosis, and that is considered a success story. Imagine that, 6 weeks with meningitis, and that's a success story. The fact I was only prescribed 2 unnecessary courses of antibiotics is a success story. The average valley fever patient, even with respiratory illness, is prescribed 4 courses of antibiotics, right? And then I was prescribed antifungals. And I was prescribed a drug called fluconazole that you guys are probably mostly familiar with. It's often prescribed at a very low dose. I was started on 1,200 milligrams a day, and had that worked for me, I would have been on 1,200 milligrams of that drug for the rest of my life. In October 2012, it was determined that the drug was not working. And this was a clinical decision, a clinical failure. Was started on a second-line therapy, failed that. 6 months later, started on third-line drug. That didn't work. This is a drug called voriconazole, which you are also probably mostly familiar with because of its use with aspergillus. So they said, we've got an idea. I met this wonderful neurosurgeon who reminded me very much of Ferris Bueller, who put this Ommaya reservoir in my head and said, we are going to give you a wonderful drug, the OG drug called amphotericin deoxycholate, and we're going to inject that directly into your brain. And as horrible as that sounded, it worked. But like most of these drugs are extremely toxic. I mean, my body completely rejects it. If you put that, and I've had it done, I'm still reliant to some extent on this drug. If that drug is injected into my port within 30 minutes, I become violently ill, almost to the point of blacking out. So and when I was diagnosed with a 70-year-old test and treated with a 60-year-old drug. Imagine that. And that, again, is considered a success. And that is the core problem with antimicrobials and diagnostics. And fungal patients, our lives intersect with those with AMR, not just because a disease like cocci is moving north and east and things like that, but you have other infections here. You have Candida auris that's impacting as a secondary healthcare infection, and that's difficult. And I had some notes because I wanted to get a couple statistics. So a little bit more about antibiotic overuse. So it's estimated that about Canada in the National Action Plan, which I'm going to give you a little interesting thing about the National Action Plan. So the word antimicrobial is used approximately 139 times in the National Action Plan for Canada. The word antibiotic is used about 22 times. The word antifungal appears once. The word antiviral appears once. And all of the efforts and all of the data and all of the deliverables are focused on antibiotics. And that, you're not alone in that. Even the UN high-level meeting, the political declaration on AMR, all the deliverables are driven by antibiotics. And there's a gap there, but because 25% of antibiotic prescriptions in Canada are estimated to be unnecessary, 28% in the US, according to CDC JAMA in 2016. But the WHO estimates globally 50% of the antibiotics that are prescribed are unnecessary. So if all the deliverables are on antibiotics, we're not addressing the underlying healthcare needs. And that allows us to talk about stewardship, which I know you're going to be talking about quite a bit, and the lessons that we can learn from and the value of preserving these antibiotics. And one other thing I wanted to share about fungal diseases is we talk a lot about AMR and One Health, and we talk about the need to be aware of antibiotic use in agriculture, right? What we inject our meat and our animal products with. But before you can inject an animal with an antibiotic, you have to feed it, right? So in AMR for antifungal resistance, that is emerging from predominantly from agricultural use of pesticides. So the same products that we are using to prevent fungal diseases in crops are the same systemic actions that we use to treat fungal infections in people. And there are very limited options already with fungal diseases. So the concern is that if we wait, we are going to have to be struck with this diabolical choice between starving to death or dying of a fungal infection or an AMR infection potentially. And that's something that we need to be aware of. And so the solution to that is diagnostics and stewardship. And a byproduct of that is having the data that we're currently missing on AMR. And I know that you're going to talk a little bit about more of that on your story, so we don't have the timer that I can see, so I don't know how much time we have. So I apologize for going a little bit long, but.
You're good, no worries. So, it ties into what you're saying with antifungals and how quick we get tested. And it reminds me of one of the stories where, I'm on antibiotics often, and I use antibiotics not for cure. I use them as a survival. Bacteria is always running around in my lungs. I'm always having some bacteria of some sort. So I'm really just at the mercy of antibiotics and it working so that I can win the fight and win the next one coming up that we know is coming. We just don't know when or how. And when you talk about, fungus, I actually, because I take a lot of IV antibiotics, I had a central line access, a port that I did lose because of a fungal infection. And we didn't think fungus, in CF, we're thinking bacteria, we're aiming bacteria, we're treating bacteria. So the fungus had time to actually enter the bloodstream, make me really sick for, days before we even think about testing for fungal infections. And this got me to lose this central access line that I depend on to go out and live a normal life with antibiotics. And, like you said it with diagnostics take time. The threat can be viral, it can be fungal, it can be bacterial. We don't necessarily get automatically tested for all three. So we're not necessarily going to know what's going on, and we're often treated before we even know what's going on. And most of the time, that's antibiotics. We're going to get treated with antibiotics. So bacterial cultures, if we do them, takes days or a week to get results. Fungus, I think, takes like weeks up to months. Mycobacterium, which is another one, can take even more to months to get the answer. So we're really not getting fast enough testing to know what we're doing. And then it comes to the question of, will these antibiotics even work? Do we have an antifungal? Do we have an antibiotic that's going to help us? And are we even on the right path? Why diagnostic can be important and why this is the case is that, I spend so much time in the hospital. If we're looking at admissions that I've had, it's an average of 3 to 4 admissions per year. And each admission is 2 IV antibiotics at a time. It's 2 to 3 weeks at a time. So it's one step more of possibly having a resistance. And because diagnostics take time, we're also not sure. So I've already been in hospitals for 2 weeks at a time just to realize these antibiotics are not the right one. And we need to change them again for another 2 weeks. Right now, with all the admissions I've had, we're at a point where, because of so much antibiotic use, for my case, oral antibiotics is no longer effective. It's not going to be strong enough to really hit the bacteria. I would need 2 IV antibiotics, because 1 IV antibiotic is not enough to fix, or not even fix, but to keep the bacteria at bay for me right now. And the scarier part is that right now, because I am with multi-drug resistant bacteria from all the bacteria use, the antibiotic use, I only have 2 antibiotics left as options that are actually going to be sensitive to the bacteria I have in my lungs. And that is the case for right now. I honestly don't know if that's going to be the case the next time I'm sick. I don't know if that's going to be the case for the next year. The hard part also is that when I was on these 2 antibiotics, the last admission, I happened to have a really massive lung bleed. So I started coughing up blood all night. The team tried their strongest efforts, and when you see a senior nurse panic, you start to panic. When you know that there's a nurse there that's been doing it and seeing this and done everything, and they're starting to worry, you start to worry. And that was a scary night. That was a night where the question came of, is it even worth the risk at this point? Were the antibiotics worth the risk? Should I have even come to get treated because of this, consequence that I have? And I remember thinking, am I even going to make it through the night? Is this how it's going to happen? And I texted my dad. I couldn't say everything. I just texted saying, it went for the worst, and no, we're not winning. And short of anything else to say, really. When you're faced with that, you start to realize, is it going to happen again? So luckily, the next day, I did get emergency procedure to stop the lung bleed. But they did say that it can come back. That brings to mind of, was it worth it? Should I go to the hospital to get treated? Is the antibiotics the right one? And not to mention, I guess, all the paperwork and the access to care. So getting these 2 last antibiotics that I could get that are sensitive for my bacteria is not as easy as a prescription and go home. It takes special authorization. It takes a lot of paperwork. So essentially, my discharge and survival depended on that paperwork, not just the medicine. And you have to stop and wonder how many lives are lost waiting, how many are declined from access to this treatment. Maybe some can't afford access once they do get it. So it's a lot of things to keep in mind. And I think we both kind of agree that because the resistance is affecting me. It's affecting, the chances of his care moving forward. And it's not only our story. We heard it in the beginning. Resistance can affect certain areas differently than other areas. Resistance can affect the immunocompromised. So if I stay near someone with cystic fibrosis, and I can transmit my resistant bacteria to them, and all of a sudden they are resistant, and I cut off a chunk of their treatment.
So how many people, so there's a strong sense of community in the cystic fibrosis. It's not, but the disease itself is very isolating, right? So I know that statistically people with chronic disease have about a third of us deal with some type of depression associated with it. It's life-changing, yes, we say that, but it's not life-changing just because of the medicine. It's life-changing because what it does to your family and your home life, and these, every time you go to the hospital, it stops your life, and it stops the life of your family and your friends. But the people that understand your situation most, those with cystic fibrosis, you have to self-isolate from them. Mm-hmm. So talk a little bit about more like, is it difficult to connect with people that have and understand your experience because of that?
Of course. You got it right on the nose. So I can't hang around with someone with cystic fibrosis. That would be detrimental to them and me, depending on what we share as bacteria. And so oftentimes you're trying to look at this from social media to try to connect with the internet. So Facebook is my friend as a result of that. Because yes, it is detrimental, and we don't know, I can't always know who's in the room. There might be an immunocompromise. I might be giving this resistance without knowing it, without wanting to. And just to think and sit that there's only, 2 left of a possibility, and I don't even know if this works next time is a big issue to consider, because if I were to give that,
it's very
else,
scary.
Yeah.
And it's very daunting, and it's it's very important that you've shared your story, because I don't think people understand exactly how everything that you've put in front of you just tries to tear you down, and you have to get over that. And it's not just the disease, and it's not just the social aspects, but it's then the barriers of getting to the next antibiotic, mm-hmm. and getting the drug approved, mm-hmm. and not just the drugs for your cystic fibrosis, but the antibiotics.
The antibiotics, the antifungals, so we don't always get the right answer right away, and this causes this delay, where we're almost wondering, and I think you noticed that when you went to the urgent care, of is it worth going here? Am I going to get the right thing? Am I, because we do have that idea of wanting to help. The doctor wants to help. The doctor wants to do something, make us feel better. Mm-hmm. And diagnostics take too long.
Do you think that if there was an antibiotic or a test that you could get at the point of care, do you think it would improve not just your health outcomes, because I'm sure it would, but do you think that the psychosocial aspects of your life would be improved by having access to that diagnostic as well, the quality of your life?
Yeah, rapid diagnostics can make a big difference for reducing that resistance, because then we're finding out what we need to actually treat. And we're not going based on the history or a guessing game of analyzing risk.
It's a little bit of self-confidence in that as well, right? Because you have answers instead of assumptions.
Right. And I think it's important to realize that this isn't just our story. I think that resistance is spreading, and it's the story, honestly, of every patient who runs out of options. It's the story of every doctor that doesn't have anything else to give or to offer as a solution. It's the story of every researcher trying to create the next lifeline. And each new antibiotic or new antifungal or new antiviral can give that chance to do more. So I really think that resistance isn't waiting at all, and neither should we.
Okay.
I thank you all so much for your attention, and I thank Biomérieux as well for letting us be here.
Yeah, and I wanted to ask one other question of you.
Yeah.
So, because we had talked a little bit about some of this, and we talked a little bit about antibiotics, but, you know, when you go to the hospital, what's that experience like? I mean, do you go in and you just know, and your doctors just kind of meet you there, or is there still a process for you to get in and just to get the process started of getting that antibiotic, and how often do you have to do that?
The process is not as long to get in, but it's a lot of, you know, I would call it like a guessing game. It's, you know, you go in with your explaining your symptoms, and it's more like, well, what did we give you last time? Let's try to give you this. Let's see how you respond. And we won't get the answers and we won't get the diagnostics until you're done your course of antibiotic. That's really the reality.
Yeah, I think we're kind of both victims of, we as a population are victims of our success. Mm-hmm. So we have successfully prioritized and made available broad, cheap antibiotics. You know, we have the convenience store availability of antibiotics within our healthcare system. And because of that, we've you know, there's always this trade-off. When you make something a priority, you disincentivize something else. And so what we've done as globally with healthcare is we have disincentivized diagnostics. We have prioritized availability over answers. Mm-hmm. And I think that's one of the most important things that we can use to change the discussion around AMR. So I did some very, very deep research into the Canadian psyche when it comes to AMR and diagnostics and antibiotics by walking across the street from the hotel and talking to some patrons at a bar. And learned quite a bit actually about the Canadian healthcare system. Learned about the structure of the government, the role of the provinces. It really was very impressive. But I learned how little educated, college-educated, knowledgeable white-collar Canadians are about AMR and diagnostics and antibiotics. In discussing with them, I'm like, so that being, if you knew that 20 to 50% of antibiotics are unnecessarily prescribed, would you rather have a diagnostic give you an answer telling you don't need something and maybe you can go to over-the-counter medication? Or would you rather have just an assumptive prescription? And when people are educated, they choose diagnostics over antibiotics. So I think it's important that we get back to that, to that equal valuation and rebalance the scales to answers are equivalent to antibiotics. Mm-hmm. And even better, right? Having the answer to the question is better than guessing what the answer is.
Yeah. I think that we're, you know, not everyone is as educated to want to know to ask for that.
But you know, as people become educated, like you've become an expert in CF and antibiotics because you've had to. I've become an expert in fungal because I had to, and I had too much time on my hand. But you know, I think if we can educate people and reach them where they are, and I think Canada has the opportunity to really be a leader in this globally. I think the broad variable populations across the different provinces, that they can be, efforts here can mirror what's done, can be done around the world in all the different corners of the globe, if you will.
Yeah, absolutely.
Thank you.
Thank you, everyone.
Thank you.